Lesson 4. Treating depression, the three-pillar model. Depression is a disorder with a high risk of relapse and a chronic course. Research conducted over several decades shows clearly that a single depressive episode rarely remains an isolated event. In a significant proportion of patients, the illness follows a cyclical pattern, and each subsequent episode increases the likelihood of further ones while worsening the long-term prognosis. Epidemiological data also reveal a darker aspect of depression that is rarely addressed directly. Among all mental disorders, depression carries one of the highest risks of suicide. It is estimated that from several to more than 12% of people suffering from severe depression will attempt suicide at some point in their lives, and this risk rises markedly in the absence of treatment or when treatment is discontinued prematurely. What is particularly alarming is that suicidal thoughts and impulses do not always correlate directly with the subjective intensity of suffering. The patient may appear calmer while the actual danger increases. Equally concerning are data on relapse and chronicity. In people who have experienced a depressive episode without adequate treatment, the risk of another episode in subsequent years rises significantly. Each successive episode tends to occur sooner, last longer, and respond less effectively to treatment. Depression that is untreated or treated only fragmentarily is increasingly less likely to end in full remission and more likely to lead to persistent functional impairment, social isolation, and reduced quality of life. From a clinical perspective, lack of treatment is therefore not a neutral choice. It is a factor that genuinely worsens prognosis and increases the risk of the most serious consequences of the illness. This is a fact. At the same time, the social image of depression still rests on the belief that it is a temporary state that will pass if the patient rests, changes their attitude, or finds the right motivation. Clinical data show the opposite. Without treatment, the risk of symptom consolidation, progressive functional impairment, and relapse increases with the duration of the illness. Research on treatment effectiveness also indicates that relying on a single therapeutic tool yields only partial improvement. Pharmacotherapy alone may lead to symptom reduction in some patients, but relapse rates after treatment discontinuation remain very high, especially when no other interventions are involved. Psychotherapy alone, without biological stabilization, often proves insufficient in moderate to severe depression because the patient lacks the psychological resources necessary for therapeutic work. Long-term data clearly show that the best outcomes are achieved with combined treatment. Integrating pharmacotherapy with other forms of intervention not only shortens the time to remission but also significantly reduces the risk of relapse in subsequent years. Multimodal treatment is therefore not a more ambitious or more comprehensive option for selected patients. It is, or should be, the standard derived from observation of the illness course. It is also worth emphasizing that depression affects a patient's ability to assess their own prognosis. People with depression often either minimize the risk of relapse or, conversely, lose faith in the possibility of improvement. Both mechanisms are part of the illness, not an objective and reliable assessment of the situation. For this reason, therapeutic decisions cannot be based solely on the patient's subjective sense, but must take into account evidence from research and clinical experience. From a prognostic standpoint, what matters is not only whether treatment is initiated, but how it is planned. A one-dimensional approach increases the risk of incomplete remission, relapse, and symptom chronicity. A holistic approach significantly improves the chances of sustained functional recovery and reduces the overall cost of the illness, both psychological and social. This knowledge forms the starting point for the remainder of this lesson. If depression is a multilevel disorder and prognosis improves only when treatment addresses more than one area of functioning, it becomes necessary to understand why single tools fail and how combining them creates a genuinely therapeutic process. 1. Why single tool treatment leads to apparent improvement. In clinical practice, what is most often observed is not a complete lack of response to treatment, but a partial one. The patient reports that it's a bit better, that tension has eased, or that a temporary sense of relief has appeared. From the outside, this may look like the beginning of recovery. The problem is that the improvement concerns only one area of functioning, while the others remain deeply disturbed. This mechanism accounts for a large proportion of relapses and for the false sense of treatment effectiveness. When pharmacotherapy alone is used, emotional stabilization and a reduction in psychological suffering often occur. Symptoms become less intense, suicidal thoughts diminish, and the patient functions more calmly. At the same time, however, their lifestyle, social relationships, and daily structure remain unchanged. As a result, the improvement rests solely on biological support. After medication is discontinued, or at the first major stressor, the mechanisms of illness quickly reassert themselves, and relapse can be abrupt and deeper than before. A similar pattern appears when treatment is based exclusively on psychotherapy. The patient begins to understand their mechanisms better, can describe emotional states more accurately, and sometimes even formulates rational conclusions about their life. At the same time, an overloaded nervous system and disrupted biological regulation mean that this insight does not translate into real change. Therapy starts to feel like an effort beyond one's capacity, and the lack of tangible effects generates guilt and a belief in one's own incorrigibility. Another variant of apparent improvement is activation without prior stabilization. In the initial phase, the patient may function better thanks to structure and external stimulation. There is a sense of returning energy and agency. However, without emotional and biological regulation, such activation quickly leads to overload. Fatigue, frustration, and a sense of failure appear suddenly and often culminate in a sharp collapse, which the patient interprets as proof of personal weakness. The common denominator in all these scenarios is the mechanism of false improvement. Treatment addresses one level of functioning while depression persists on the others. What is particularly dangerous is that the moment of partial improvement is often interpreted as the end of the crisis. This is precisely when patients most often abandon further treatment, reduce vigilance, or make decisions for which they do not yet have sufficient psychological resources. From a clinical perspective, this is not the patient's fault, but a consequence of poorly planned treatment. Depression rarely resolves evenly. If improvement affects only one area, mood, insight, or activity, it is not recovery yet, but a temporary weakening of symptoms. Without parallel intervention on other levels, the illness mechanism remains active and ready to be reactivated. This leads to a simple, though uncomfortable, conclusion. Treating depression requires the simultaneous use of several tools not because it is more ambitious, but because only such an approach reduces the risk of false improvement, relapse, and the most severe consequences of the illness. 2. Pharmacotherapy, a necessary intervention with a real risk of dependence. Pharmacotherapy in the treatment of depression is not a neutral form of support, but a powerful intervention in the functioning of the nervous system. Its use is often indispensable, especially in severe states with a high risk of suicide. At the same time, it is an area of treatment burdened with one of the greatest long-term dangers, the risk of dependence and pharmacological withdrawal from reality. The history of psychiatry and medicine offers particularly painful examples in this regard. In the United States, the mass and long-term prescription of sedatives, anxiolytics, and painkillers led to one of the greatest public health crises of the 20th and 21st centuries. Benzodiazepines, opioids, and other substances acting on the reward system were treated for decades as quick solutions to psychological and existential problems. The result was a wave of addictions, overdoses, and lasting social exclusion affecting millions of people. Valium, Xanax, and other drugs from this group were not only prescribed on a massive scale, but were even culturally promoted as ways of coping with tension, frustration, anxiety, and dissatisfaction with life. Television advertisements and medical narratives suggested that emotional suffering was a chemical problem that needed to be balanced. In practice, this led to a situation in which treatment began to replace life itself, and pharmacology took on the role of a long-term psychological prosthesis. Pharmacological dependence in depression does not always take the form of a classic craving for a substance. It is often more subtle, yet equally destructive. The patient gradually loses the ability to function without chemical support. Fear of dose reduction appears, along with anxiety about the return of emotions and a reluctance to confront reality. The medication ceases to be a tool and begins to function as a regulator of emotional life. The person functions, but in a state of pharmacological suspension. It is precisely this mechanism that makes pharmacotherapy used as the sole method of treating depression particularly dangerous. It reduces suffering while simultaneously cutting off access to the emotions necessary for change. The patient does not suffer enough to seek help through relationships and action, but does not function well enough to rebuild life independently. A state emerges of chronic, chemically sustained existence which, contrary to the patient's true interests, may be consciously maintained by the pharmaceutical environment. Assuming that drug production is a charitable humanitarian initiative of wealthy benefactors may be naive. Medication should be viewed critically, not as an elixir of calm and happiness without which everyday life supposedly loses all color. For this reason, pharmacotherapy cannot be the goal of treatment, but only its temporary foundation. Its task is to secure the patient during the phase of greatest danger and to create the biological conditions for further therapeutic work. From the outset, it must be planned as a transitional stage, not as a long-term solution to an existential problem. Responsible treatment of depression therefore assumes parallel actions. Pharmacology reduces risk and stabilizes the nervous system. Psychotherapy enables confrontation with reality, and behavioral therapy restores agency and relationships. Detaching pharmacotherapy from these two areas leads either to relapse of the illness or to the consolidation of pharmacological dependence, which has less and less to do with healing. In this sense, pharmacology is a double-edged tool. Without it, many patients would not survive the most severe phase of the illness. With it, used improperly, many patients never fully return to life. Therefore, it must occupy the first place in treatment, but it must never be the last. 3. The limits of psychotherapy without biological stabilization and the risks of the therapeutic market. Psychotherapy is often presented as a safe and sufficient alternative to pharmacology, especially in narratives emphasizing the natural or deep paths to healing. In cases of moderate to severe depression, however, such an approach can be not only ineffective but also risky. Psychotherapy does not operate in a biological vacuum. Its effectiveness depends directly on the condition of the patient's nervous system, and in depression that system is often functioning in a state of chronic overload and alarm. In the absence of biological stabilization, a patient's capacity for concentration, reflection, and emotional regulation is limited. Ruminative, catastrophic thinking and pervasive guilt dominate. Under such conditions, psychotherapy, rather than bringing relief, may be experienced as yet another demand beyond one's strength. Conversation does not lead to change, but to increasingly precise descriptions of one's helplessness. Insight grows, but functioning remains unchanged. Therapy begins to resemble the analysis of wounds without any possibility of healing them. A particularly dangerous mechanism is the shifting of responsibility onto the patient. When therapy fails to produce results, it is easy for a message to emerge, sometimes explicitly, more often implicitly, that the patient is not working hard enough, not ready, or resistant to change. In depression, such a message does not motivate. It deepens guilt and consolidates the belief in one's own defectiveness. The illness is interpreted as a lack of effort rather than as a condition requiring biological stabilization. The lack of stabilization has another serious consequence. A desperate patient who feels no improvement despite intensive therapeutic work begins to seek help elsewhere. The market of psychological and quasi-therapeutic services is vast and poorly regulated. Alongside competent professionals, there are individuals offering energetic, shamanic, magical therapies or approaches based on the authority of a guru. Some act in good faith and with genuine belief in the effectiveness of their methods. The problem is that good intentions do not replace clinical efficacy, and depression is not an area in which long-term experimentation is safe. This risk also applies to formal psychotherapy. There is a wide gap between quality and accessibility of services. Certifications and formal training do not always go hand in hand with clinical competence and ethical patient care. Some therapists work under conditions of overload, others treat therapy primarily as a source of income, and the prolonged duration of the process may, consciously or unconsciously, be prioritized over the patient's real benefit. For a person with depression, this means the risk of becoming stuck in a process that does not lead to improvement, but merely maintains the status quo. In clinical practice, many patients are encountered who have spent years in various forms of therapy, can precisely describe their schemas, relationships, and childhood experiences, yet remain unable to return to basic functioning. Knowledge does not translate into change because the organism was never provided with the biological conditions necessary to implement it. Psychotherapy without biological stabilization becomes an intellectual process rather than a therapeutic one. For these reasons, Psychotherapy cannot be treated as a standalone method for treating depression in states that require pharmacological intervention. Its proper role is to work with psychological material after biological overload has been reduced, not instead of it. Medications are not a negation of therapy. They are the condition under which therapy ceases to be a struggle for survival and becomes a process of real change. If this condition is not met, the patient is exposed not only to a lack of improvement, but also to drifting into areas of illusory help that consume time, money, and hope without reducing the risk of illness. Responsible treatment of depression does not consist in choosing a purer or more appealing method, but in combining tools in a way that genuinely increases the patient's chances of returning to life, rather than merely talking about it for years. 4. The limits of activation alone and lifestyle change. Activation, physical movement, daily structure, sleep, diet, and broadly understood life hygiene now occupy an important place in narratives about treating depression. Under certain conditions, these elements can genuinely support the recovery process. The problem begins when they are treated as a standalone method of treatment or as a condition a patient must meet in order to deserve improvement. In depression, lack of energy, irregular sleep, neglect of self-care, or social withdrawal are not choices or personal failings, but symptoms of the illness. Attempts to reverse these effects by force, without prior biological and emotional stabilization, very often end in a short-lived surge followed by a sharp collapse. The patient functions better for a moment, then experiences an even deeper downturn, which is interpreted as a personal failure. Equating activation with motivation is particularly problematic. In depression, motivation is not the starting point but the result of treatment. Expecting the patient to begin acting regularly in order to feel better reverses the natural sequence of the therapeutic process. Regularity, sleep hygiene, physical activity, or daily structure begin to have an effect only when the nervous system is no longer in a state of constant overload. Social activation can be especially risky in this context. Forcing a patient into intense social contact, work beyond their capacity, or participation in activities that do not resonate with their emotional sensitivity is a systemic error. Depression is not merely a lack of activity, but a disturbance in the relationship with one's own emotions. Action that does not address this area becomes mechanical and exhausting, even if it appears healthy from the outside. What matters most, therefore, is not activation itself, but its selection. Effective activation must correspond to the patient's emotional profile. For some, this will mean a simple daily rhythm, basic responsibilities, and caring for the body. For others, it will be contact with another person, a caregiving relationship, or a sense of being needed. What unites effective forms of activation is that they trigger at least minimal emotional resonance, not merely task completion. Regularity, life hygiene, and daily structure are not ends in themselves. They are tools meant to support the rebuilding of the capacity for feeling and relating. Applied without this sensitivity, they easily become another source of pressure and inadequacy. Applied appropriately, at the right time and in agreement with the patient, they become a genuine component of treatment. For this reason, lifestyle change cannot be treated as an alternative to pharmacology and psychotherapy. Without biological stabilization, it risks further overload. Without work on psychological mechanisms, it remains superficial. Only as a third element, chosen with attention to the patient's emotional sensitivity, does it begin to fulfill its therapeutic role. 5. Hierarchy and parallel use of tools, treatment as a process, not a choice of method. Since each of the tools discussed, pharmacotherapy, psychotherapy, and activation, proves insufficient when used in isolation, it becomes necessary to organize them properly. Treating depression is not about choosing a single path or sequentially testing methods. It involves simultaneous intervention across different levels of human functioning, while maintaining a clear hierarchy of responsibility. Pharmacotherapy occupies the first place in this structure not because it treats everything, but because it safeguards life and psychological stability. It lowers the level of suffering to a threshold at which any further work becomes possible. Without this foundation, psychotherapy can be sterile and activation destructive. At the same time, pharmacotherapy must never be treated as the end point. Its role is temporary and instrumental. It is meant to enable treatment, not replace it. Psychotherapy occupies the second place, not in terms of importance, but in terms of function. It organizes internal mechanisms, allows experiences to be named, dismantles guilt, and reconstructs the relationship with oneself. The condition for its effectiveness, however, is prior reduction of biological overload. Psychotherapy is not a fight against the illness, but work on its consequences, and only in this context does it bring real effects. Activation, regularity, life hygiene, and social engagement constitute the third area of treatment, but they are not a reward for improvement nor a test of the patient's capacity. They are the space in which therapy materializes in everyday life. Their effectiveness depends on the timing of introduction and on alignment with the patient's emotional sensitivity. Activation is not meant to force someone to live, but to gradually restore them to life. Crucially, these tools do not operate in a one after another mode. Psychotherapy does not wait for pharmacotherapy to end, nor does activation wait for a moment of full readiness. They work in parallel, but with varying intensity, and at different times one may play the leading role. Treating depression is a dynamic process, not a linear plan. A systemic error is treating any one of these elements as unnecessary or optional. An equally serious error is absolutizing one of them as the best. Depression does not resolve because the patient chose the right method, but because treatment addressed the entirety of functioning, biological, psychological, and social. The three-pillar model is based on a simple yet very precise distinction of therapeutic directions. Pharmacotherapy works from the inside, as it directly intervenes in the biochemistry of the nervous system. It is a form of chemical supplementation for what the organism, in a depressive state, cannot produce or regulate on its own. Its task is to stabilize the basic core of functioning, reducing risk, impulsivity, and biological overload. Psychological therapy works from the top down, as it organizes what happens in the mind, patterns of thinking, interpretation of experience, relationship with emotions, and self-narrative. It stabilizes cognitive and emotional processes, enabling reflection instead of automatic reaction. Behavioral and social therapy works from the bottom up, symbolically through the legs, as it restores movement, action, and rootedness in the external world, in relationships, responsibility, and real functioning. Only the combination of these three directions creates a holistic approach. Each pillar supports the others, and the absence of any one causes the entire structure to lose stability. Treating depression, therefore, is not about choosing one path, but about simultaneously grounding the recovery process on three complementary foundations. This model is not an ideological proposal nor an alternative to medicine. It is a description of what, in clinical practice, works most effectively and provides the best long-term prognosis. Treating depression is not about quickly removing symptoms, but about gradually restoring the capacity to live in relationship, responsibility, and meaning. Summary: depression is not a disorder of a single mechanism, therefore, it does not respond effectively to treatment based on a single tool. Pharmacotherapy is a necessary foundation because it protects life and psychological stability, but when used alone it leads to apparent improvement, relapse, and the risk of pharmacological withdrawal. Psychotherapy without biological stabilization can be sterile or burdensome, and the therapeutic services market carries additional risks of illusory or unethical help. Activation and lifestyle change, when imposed or mismatched to the patient's emotional sensitivity, become a systemic error rather than treatment. Effective treatment of depression requires the parallel application of three pillars: pharmacology as protection, psychotherapy as work on internal mechanisms, and activation selected in a sensitive and meaningful way for the patient. It is not the choice of a method, but their proper integration, that determines lasting improvement.